routine testing for a patient. This is, as I recall, a squamous cell patient, stage 3. Maybe you can walk us through, ignore the histology, but stage 3, should this patient be tested at all? And then squamous cell, are those patients being tested molecularly? What's your role as a pathologist in stage 3 lung cancer?
Sure. So the primary role of the pathologist in these discussions, I have to remind people, when it first comes to the pathologist, to Lonnie's point, we don't know it's a cancer yet. So our first step is still to make that diagnosis. But pathologists today have to be thinking past the diagnosis. How's this patient going to be managed? And biomarkers are the future. I mean, that's so important to many of the decisions that are going to be made about how the patient is managed. So this is a squamous histology. However, mixed tumors are out there. I think the trend is towards more reflexive testing of all histologies. And then we have a number of biomarkers that are histology agnostic. InTrack is the latest one although it's low incidence, is in all morphologies, as well as MSI. There's a pan-tumor indication. So our approach is to be more aggressive rather than less, to get that information onto the chart so that the decisions can be made in managing the patient. Certainly, of course, PD-L1. So you've got stage 3 squamous histology, non-small cell lung cancer. Certainly, we're going to make sure we get PD-L1 and probably prioritize that above the other biomarkers because of the squamous histology. Looking at the amount of tissue you have, I think there were lymph nodes sampled in this. Presumably, we've got plenty of tissue. So then would have a discussion because of the squamous histology about how much additional testing may be required or may be desired. We have some hospitals we serve where we have an understanding that even in a patient like this, we're going to reflexively do the standard hotspot biomarkers. If those all come back negative, we kick it back to the treating physician to decide how they want to if order additional biomarkers, perhaps after a conversation with the patient. So certainly in this patient with the squamous morphology, you're going to want to get PD-L1 testing. Next generation sequencing may be considered. Microsatellite instability, some of the other pan-tumor markers might also be considered.
Okay, you mentioned reflexive testing and how important. Is that sped things up for you guys? We've had challenges at my former center and my current center, whether all tissue should be sent off or not, and should it be reflexive or should it be really on that the medical oncologist should be calling and saying, hey, I want this sent off. Has it been helpful to do reflexive testing because it essentially assures that every patient is getting testing done, and have you found that to be helpful in terms of expediting the results?
Absolutely. So I'm both a fan and an advocate for reflexive testing because I think if you don't just do it across all tumor types or across all patients, the pathologist will forget to do it. I mean, it can get lost, and so you have to have a fairly simple protocol. Also, the turnaround time. I'm not sure pathologists are always as sensitive to the clinical timeline and the need to have that information in the decision making. Within our institution, we were one of the first in our community to go live with reflexive testing in non-small cell lung cancer several years ago, and quickly got feedback from the oncology community. I heard at other institutions as well that it was great and they wanted it done the way it's done at our institutions. Sometimes I think pathologists need to get more on board with this. Certainly it's an opportunity for the multidisciplinary team to come together and discuss what's going to be done and let the pathologist know it's important to have that information.
In a perfect world, we'll have binary histological assessment. We've got squame or we have adeno, but that's not always the case, right? There are times it's really tough to tell, and I pushed my pathologist, can you tell me what this is? How often does this happen and why does it happen? Are these poorly differentiated? Are the immunostains not aligning? Is this just tumor biology? You're gonna get adenosquamous or poorly differentiated 10, 15, 20% of the time? Walk us through kind of your thought.
Well, so I think part of this goes back into history. It didn't matter. We call it non-small cell lung cancer. The pathologist knew for treatment purposes that was sufficient. Yeah. And so there wasn't a lot of focus on adeno versus squame. These are presumably coming from the same pneumocytes as the cell of origin. So there's really a continuum. I mean, it shows some features of squamous, some features of adeno. Some clearly are well differentiated in one category or the other, but it's biology. Nothing's 100%, and these are the same cells just kind of showing different features. So I think it's going to depend on the pathologist. Sometimes the immunohistochemical stains that we use will suggest one or the other. Sometimes it's very clear cut. Often it's not. I think the guidelines recommend if it can be called clear cut, do so. Otherwise, say favor one or the other.
Yeah. One more question. You know, as a medical oncologist, my best friends have become the pulmonologist and the pathologist, and I try to call them at all times. Hey, did you get enough tissue? And then I talk to the pathologist. Do you have enough tissue? How often are you getting? I mean, what's the communication like? Has the changes in molecular testing altered how frequently you're speaking to the medical oncologist, or is it pretty operationalized where you don't really need to have that conversation? Everything's kind of done in a reasonable way.
We tried to operationalize it. So we had within our COC accredited cancer program, one of the studies we did was looking at the adequacy of specifically lung biopsies for biomarker testing. And I think that helped raise awareness across the institution of the need for an adequate tissue sample. What was interesting is we found there were not significant increase in the side effects when our interventional radiologists were doing the biopsies, and they became a little bit more aggressive in the wake of that. Even under optimal circumstances, I think you're going to end up with a 10 to 20% QNS rate. The lung is a difficult organ to get a generous sample, but it's important to get the tissue when you can.